Hi, my name is Bernie Wright. I work as a specialist in eating disorders and obesity, and I have done for many years. Generally, I work with and for the National Centre for Eating Disorders as a mentor, a trainer, a practitioner, and a supervisor of their network, and anybody else who suffers and works with eating disorders in this way. The reason I decided to train in this field was on my placement many years ago. I was working with a young lady, and after a long time I worked with her, I asked if there's anything that I could support her with. And sadly, she said, yes, Bernie, I would have appreciated it if you'd have supported me with my purging and vomiting. And I felt really sad due to the fact that I've been working with her by that time for over a year. And I had no idea that after most sessions, I should imagine, that in order to deal with her emotions that came up in session, she was, as I realise now, purging them down the toilet. So after that, I decided that I would go and get trained with the National Centre for Eating Disorders in London in this very field. And I work as a master practitioner in this field today. Now, I never, ever forget to ask, what is a client's relationship like with food, weight, and shape? In fact, after that session with that young lady, I asked everybody. And at that time, I was shocked by how much of our population suffer in this way with food, weight, and shape, whether they are in fact overweight in a larger body or underweight in a smaller body. And this video is basically an attempt to give you an idea of the tragedy of eating disorders, and also, if you're a practitioner, an idea of people and how they suffer in this way and how you can support them. And indeed, when you're working beyond your level of expertise and competence. So basically, this is purely an introduction in how to work in this field. Disordered eating is now the Western norm. It is literally taken over. 50 to 75% of women suffer from eating disorders. 28% of men have eating disorder behavior. And fundamentally, any diet that we talk about is in some way disordered eating, whether it's Weight Watchers, keto diet, slim fast. It's all an attempt of telling you how you need to eat, when you need to eat. Or people even smoke in an attempt to keep their weight down, which has always saddened me greatly due to the fact that, yeah, people would rather die of cancer than be overweight, which is terribly sad. Social media is clearly hugely responsible for so much of it. And it has got so much worse recently. I say to my clients when they're talking about, I need to look like a model, I would say, yep, and so would they, as we're filtered, redefined, and changed, often beyond even any recognition. And so for our clients, that's a tragedy, due to the fact that they have got no idea anymore what they need to look like, how they need to be, and who they indeed are. And eating disorders, unfortunately, are literally that. They're an attempt to have another identity and to create another way of being. And in that other way of being, we create a total tragedy within our very, very world. Everywhere we look, there are eating disorders. Everywhere we look, there is pain and suffering. So the truth is, food is the most abused anxiety drug, and exercise is the most underutilized antidepressant. And I'm not talking about the torturizers. I'm not talking about those people in the gym whose eyes are dead and they're running to nowhere. So decent food, decent nutrition, and moderate exercise without being compulsion is indeed the way forward. So as a practitioner, I have very little interest in labels. People come to me with all sorts of labels. I'm bulimic, I'm an anorexic, I'm this, I'm that, I'm a compulsive eater, I'm a binge eater. And basically I ask 4 questions. Does eating rule your life? Do you think about food, weight and shape a great deal? Are you unhappy, undistressed about your eating? And does it cause either yourself or others a lot of pain and anguish? And is some of a lot of your behavior done in secret? And literally, if you ask yes to all 4 of those questions, then it's irrelevant. You need support with your eating behavior. So remember, every eating disorder has a purpose. It has an intention. Control, safety, I'm good at this. I don't have to grow up. I get lots of attention. It is my identity. And never ever underestimate just how much of an identity for people it truly can be. But there's a great saying, every behavior has a good intention. And I say to my clients, even if I had a magic wand, I would not take your eating disorder away because it would leave a void. And our job as practitioners is to support our clients with strategies and healthier learning strategies in order for them to live a different life. So we forget the side effects each and every diet puts us through. And arguably, each and every client I work with, when they come to me and I do what we call a weight line and a lifeline. And sadly and inevitably, it appears to start a huge amount of time by that first diet they ever went on, whatever diet they ever went on. And basically what we all forget is that it absolutely ruins your innate hunger. It forgets to support you with your hunger, your fullness cues. It slows down metabolism. It creates a hunger monster, overeating and binging. It undermines your own innate ability to recognize hunger and your own fullness. It relies on someone else to tell you what to do, which can easily result in eating too little or indeed eating too much. Loss of muscle mass, rebound weight gain, food obsessions. I'm sure anyone watching this will remember or know that was the very first time they went onto a diet. It's literally all you think about. It's a preoccupation. What will I eat next? Is it time for the next meal? How long will I eat before I need to eat next? And the deprivation backfires always. And basically what happens is, it's you starve, and then you find yourself absolutely wanting to eat everything that's not nailed down. That is a reality of dieting behavior. So what is the reality? The reality is like the iceberg. It is what you see. So you've got the iceberg on the top, on the part that you see, and underneath is what's really happening. And what I want to really emphasize to everyone watching this tutorial today, this video, is please do not assume that people who are of ordinary size or an average size do not suffer from anorexia nervosa. So often they do. Very few of our clients actually would present in a skeleton figure. That is not exactly as it is. They often look normal. And what we don't also understand is that 50% of people who are in larger bodies suffer from eating disorders. So we can't go by just what pops out of the iceberg as normal behavior, because what is underneath the iceberg is huge, huge anxiety. It is not called bulimia nervosa and anorexia nervosa for nothing. It's called them for very good reasons. Nervousness, anxiety, depression, tension, panic attacks, fear, terror. And please do not underestimate the terror of us supporting with people, especially those suffering with anorexia nervosa, the terror of supporting them to eat. Basically, eating disorders are the thieves of souls. If you ever look into someone's eyes as they're spiraling out of control, because what we need to remember with eating disorders, that we start off as a master. We are the master, and the servant is the eating behavior. But what happens so quickly and so scaringly is there's always a switch in the game, and we become the servants to the master, which is the eating disorder. And we are no longer remotely in control. It is the thief of souls. Because it promises one thing. It promises one thing. And yet it's a total illusion of control. It promises you beauty, perfection. It promises you that just be this size and your life is going to be amazing. Just look like this and you will be happy ever after. It is an illusion, a false path, a false road. So it promises one thing and quite beautifully delivers another. It is both a seduction and an imprisonment. A seduction and an imprisonment. And basically, it creates this body image is so behind so much of this behavior, so driven by poor self-esteem, poor body image. And the sad thing is, bodies are now not meant to be lived in. To me, the longer I work within this profession, they appear to me to be worked on. And I say to my clients, and please say the same to yours, if you're building your self-esteem on your shape and your weight, then it's a very precarious way to build your self-esteem. So when we work in this field, what we forget, what we don't understand often, is that we're working with three people in the room. We are working with the voice of the eating disorder. One client described it to me as the devil. Parents talk about their children being possessed. People talk about the film The Exorcist and liken their children's behavior to that. And I have seen in my consulting room the voice of the devil, the voice of the possessed. And it's a really critical voice, and nothing you can ever do or say will support this voice to quieten until we feed the brain, until we restore the brain, and until we work therapeutically in this field. And I mean therapeutically with knowledge and experience. There's a brilliant YouTube with Laura Hill who it's called Eat from the Inside Out. And it is excellent. It will show you beautifully what that voice does to people. So if we start on some of the eating disorders, and there are many, and the thing they all hold in common is the misery and the pain and the anguish that they inflict on both of our clients and our loved ones and anyone who comes in contact with the people suffering. So we have compulsive or binge eating disorder, which is BED, which is absolutely the biggest eating disorder out there. The most people you will meet and work with will suffer from that. People overeat in secret, either all the time or some of the time. They know that their eating isn't normal. They feel guilty about what they eat, anguish about what they eat. They try to lose weight or try to stop themselves from gaining weight. It is a relentless and tragic cycle to find ourselves on. And they think about food all of the time. And I mean all the time. They feel out of control around their food, and certainly certain types of food that they know that they would not be able to stop binging or purging on. So they eat in a discrete period, an amount that most people would find hugely more than would be possible for them to eat for a normal, whatever normal is, appetite. Total sense of lack of control. But the thing about binge eating, a BED, is they don't tend to involve themselves in other compensatory behaviors like running or over-exercising or or purging or vomiting, purging, or indeed using laxatives or water retention tablets in order to rid themselves of, unfortunately, the calories. And that's a fantasy, which is a whole nother subject to be discussed. And bulimia nervosa can be all of those things, combined with recurrent episodes of binge eating, sense of lack of control, irresistible cravings for food, and using compensatory behaviors like vomiting and running and doing all those other things that we do. I say to my clients often, because it's really important when you're talking to your clients to take away the shame, which is huge in this client group. So I will always say to my clients, and when I'm training, some people say that they need to vomit in order to get on with the day. Does that seem true to you? Some people say that they need to throw every meal they eat down in order to feel emotionally better. Does that ring true for you? It takes away the blame and it makes them feel that they're not on their own and that lots of other people are suffering as well. And over-exercising is clearly a huge one that people engage in. So what's really important to take on board is that not all people, I've said this before, but I think it's important to say it again, please do not be judged by how people present. You cannot go by that as an indication of their mental health. Anorexia, for example, not all people with anorexia are thin. In fact, I would say the majority of the clients that I've worked with are not. They would look like you or I, or someone who's overweight, or indeed someone who's very underweight. So weight ranges from slightly underweight to very thin, or indeed to normal weight or overweight. And yet the common denominator is that clients feel huge and are terrified of weight gain. And when I say terrified, I mean terrified. Huge, huge fear. They're very fearful of what they eat, to an absolute obsessional way. And they hear a voice telling them to eat less, telling them they're fat and disgusting, telling them they don't need that, telling them they've failed. Some anorexics vomit or use laxatives after normal meals. and snacks, or they binge. Now, this any practitioner who works with this particular presentation will know that it's the most sinister form of anorexia nervosa. So the face of anorexia, the ones that end up in hospital. The face of anorexia, stable anorexia or chronic restricting anorexia. Chronic does not mean permanent. However, the longer you have this illness, the harder it is to remove it from your psyche, the harder it is to say goodbye to. But remembering that anorexia nervosa is the biggest psychiatric killer of all psychiatric illnesses. And a huge amount of this client will go on to commit suicide. Because what starts off as euphoric, ends up as your well gets smaller and smaller and smaller until you are literally just a dot in a huge, huge piece of paper. There's not very little left of you. So the fear and the terror of weight gain, the refusal to maintain a safe weight, the totally altered perception of body shape, and please do not underestimate this altered perception. There's all sorts of things we do as eating disorder practitioners. And when I've established a relationship with people, I may well get a load of wallpaper. And when the relationship's really established, I may say, let's draw around your body. And then when they jump up, they're temporarily horrified with how thin they are. And yet one of my clients said to me, oh my goodness, Bernie, there's nothing of me, I'm so thin. Less than 1 minute later, she was sobbing and crying. The picture, she said, had grown in front of her, and she saw herself as fat again. The periods disappear. The restriction type does not engage in compensatory behaviours. The binging and purging type does. Interestingly, and to be very noted, is that there's a 20 to 30% of the people who present to you with anorexia nervosa will be on the autistic spectrum. The relationship between autism and eating disorders is often overlooked and misunderstood, which is terrible, terrible for our clients who already suffer in so many ways if they're suffering on the spectrum, with sensory overload, fear of bright lights, terror of so many things. And then to be put into a hospital ward and treated just like everybody else who didn't suffer with those added handicaps is extremely sad and needs to be changed within our society. Neurodiversity has to be looked at and has to be accepted and has to be supported. We have Ofsted, which is formerly known, some of you may know it as EDNOS, other specified eating, feeding or eating disorders. So examples would be the atypical anorexic who presents in normal weight, bulimia nervosa with less frequent behaviours, purging disorder, purging without binge eating, night eating disorders, excessive night food consumption. And you might find that these people suffer, they may not eat hardly anything, it seems, all day. And then at a certain time, they go into total overeating and binge eating. Orthorexia is what I and many others consider to be a flight out of anorexia nervosa. We still have the huge anxiety behind it, but this one is in a pursuit of a healthy diet, clean eating. It's hidden behind an attempt to be as healthy as I possibly can. It often is comorbid, so it will go alongside depression, anorexia nervosa, and other eating disorders. So it's sort of, and please bear in mind that these eating disorders can all float in and out of each other almost. So we can go from anorexia nervosa and go into bulimia or binge eating, anorexia nervosa into orthorexia. So it's not given that it's stable, which is why it's really important. I'm saddened to say that at the moment we seem to be extremely focused, which is correct, on weight restoring our clients. And yet we forget that it's also important that we don't push them into a love for refined sugars and refined carbs. So then we push them into binge eating purely by doing our absolute best through fear and love, which is why it's important that you work with specialists in this field or people who have knowledge around this. Diabulimia is a it's a very, very dangerous condition where people withdraw their insulin in a desperate effort to lose weight. And sadly, when I've worked with people who do this, I will say, this is so sad. This is so dangerous. On saying that, please take on board that fear is hardly and seldomly a motivator for people suffering with eating disorders. So when we get into this, you can die from this, and I've felt that way myself when I've become extremely fearful. But it's just like the alcoholic that doesn't actually believe that they'll be the one that dies of alcoholism. It's no different from eating disorders. Night eating disorder, NES, it's night eating syndrome, which is comorbid often with compulsive eating or bulimia nervosa. Night eaters can become psychotic if they are put on a diet. So you have to be really careful that you don't do that you're working with specialist attention in this field. They also suffer often from morning anorexia. So they find it impossible to eat in the morning. We have other ones, feeding disorders, AFRID, avoidant restrictive. It was known originally as selective eating. PICA, it's persistent ingestion of an edible object, stones, mud, etc., etc. The rumination disorder is a repetitive, habitual bringing up of food that might be partially digested, that may be rechewed, swallowed, or spat out again and again and again and again. And a lot of my clients I've worked with have done that in an attempt to almost have their cake and eat it. So I'm not going to eat it, but I really want to taste that chocolate. Body dysmorphia disorder is growing huge in the UK. It's an anxiety disorder, again, that causes a person to have a distorted view of themselves. They may see a dot on their nose as a distorted nose. There's and basically a lot of people who have had cosmetic surgery would have been far better having therapy, due to the fact I've worked with people, by the time they got to me, there was very little of themselves left as they'd attempted to change so many parts of their body when they were absolutely okay to begin with. Once again, it's comorbid, and it can go alongside obsessive compulsive disorder and social phobia. Very few of these eating disorders stand alone. And eating disorders in particular, whether you're bulimic and you use compulsive physical activity to compensate from the binge eating, anorexics often use exercise as a desperate attempt to purge their calories, often running nowhere. And again, don't underestimate the drive for the endorphins that exercise can bring, and also the compulsion as part of the illness. And I've had many people absolutely bulk in terror when I've suggested that they reduce their exercise. One person said to me, I would rather take guns to my head than do that, Bernie. Muscle dysmorphia, which is also known as bigorexia, is also an anxiety which causes someone to see themselves as small. This condition can affect men and women, and it goes alongside steroid abuse, and they see themselves and cosmetic surgery. Both of those are very sort of go hand in hand with this disorder. And we have body mass index, which brings up so many questions and arguments, and within so many different fields of our society. And arguably, absolutely, people can present with a body mass index which is outside of range and still be very fit and healthy. Bearing in mind, people who exercise a lot will have a higher body mass index. So for me, it's a interest. It's a guideline, and it's not an absolute. However, as a general rule of thumb, if we're talking about 30 to 39.9 and over, we're talking about obese and morbidly obese. 25 to 30, we are considered overweight. The debate's out with you on that one. 18.5 to 25 is considered an acceptable range. 16 to 17.9 is when we begin to present as severely underweight, periods intermittent, or they in fact cease. 14 to 15.9, they present as emancipated, symptoms of semi-starvation. The patient is a priority. 15, inpatient consideration. Sadly, whilst it needs to be a must, beds and resources in the UK are outstandingly underfunded and understaffed. 12 to 13, hospitalisation is needed. And 10 to 11.9, death is sadly imminent. So, what's really important, and what I really want you to take away and to understand from this video, is the importance of working ethically and competently. Now, if someone comes to me, the first thing I do is to get a team involved. So I will be involved with the GP, a psychiatrist if pharmacology is needed, a dietitian, a nutrition. As a general rule of practice, anorexic presenting in private practice should be referred back to the GP with a BMI of less than 17.5. However, some CBT practitioners can work with 16. Now, once again, I can almost hear a chant out there of people listening to me and saying, but where will we send them, Bernie? It's a great idea, send everyone back to your GP. But what happens then? And that is the biggest black hole we have within our society. Again, it is grossly underfunded and grossly understaffed. There is very, very little resources, long waiting lists, and that makes it all so much sadder. A nutritionist working independently will not work with anyone with a BMI less than 50. They are unable, they are not allowed. Again, working with a GP is essential, and I was accompany immediately a letter to my GP. It is important that your supervisory work is supervised by a practitioner specialising in this field. And again, that is not easy. I myself struggle getting supervision for my work. And a person in a larger body who approaches you for support also needs a medical risk assessment. Again, that is important. So these ethical requirements, please read this slide and read this slide and read this slide again. So now we come on to what we call the conceptualizing EDs. What formulates them? What makes them? Where do they stem from? What it's like having a gun. So you put the bullets in and then you fire them. So what will fire the bullet in that gun to start the eating disorder off? And the perpetuating, what keeps it going? So if I work with someone, I fundamentally think all the time of these 3 Ps. What started it? What was behind this? What fired the gun? And what is keeping it going? These are what I look at every time I have a client in front of me. We have the predisposing factors. Again, these are the ones that would make you more likely to develop an eating disorder. More likely to develop one. Traumatic events. Birth can be a traumatic events. And anything that rolls on after that. Childhood obesity often appears to lead on to or linked to bulimia. The cultural factors, whether in your culture it is deemed a vision of perfection to be either overweight or to be indeed underweight. Perfectionism, it runs rife through eating disorders. That drive to be someone that you're not able to be, an impossible drive. Personality styles, this is a very driven. I have never worked with someone who is lazy as an anorexic, for example. There's always that drive, that it's never surprised me that they're on their way to Oxford or Cambridge. Genes, having a relative with eating disorders, it creates a percentage of up to 10 times more likelihood to develop one. Anxiety disorders are behind it phenomenally. The environment, family, background. Often the mother may have, or the father, or a member or a distant cousin. Interestingly, anorexia nervosa runs pretty regularly in twins. Maternal stress, OCD personality styles, obsessive compulsive, development and body issues. Even birth date, between April and June, seems to have more predominance or relevance to eating disorders. So what starts it? So we have the predisposing factors. We have the predisposing factors And then the life events that set the bullet, what set it on fire. So we have to have, please remember this, we have to have the predisposing factors, and always in context of not coping at the time: bullying, maturation, example, puberty, whether you come in early or come in late, which is fascinating, because because it said that 2% of people, the girls that come in early, suffer from low self-esteem, which is a contributing factor clearly to eating disorders. So they may be the young girl that comes in her breasts are developing, and she's having to go to the toilet in her lunchtime, and the gym's a trauma for her. And arguably the 2% of men, young men that go in, and their voices are broken, and people laugh at them at school, and they're aware of their differences. Divorce, separation, glandular fever. A huge amount of my clients have suffered with glandular fever. Stress or loss of animals, loss of parents, loss of grandparents, loss of loved ones, loss of friends. All of these can contribute to precipitate, to be that bullet that fires from that gun. Abuse, clearly physical, sexual, and mental abuse. Any of those can be contributing factors. Any of those can be contributing factors. So if we have the predisposing, the ones that make it more likely, the ones that make you more susceptible to eating disorders, and then if we have the life events, what starts it, we then have the final P, which is the perpetuating factors, the life events, and what keeps it going. So in order to work this out, we have to have the three, 1P, 2Ps, and the final P, what keeps it going. Starvation, clearly, often. Trauma, particularly physical, sexual, and physical neglect. Conflict, whether it's intrapersonal within yourself or intrapersonal. Low self-esteem, stressful demands, puberty, exams. It's really, it really is extremely very relevant, this, because a huge amount of my clients and my supervisees' clients will present at that age group, 15, 16, 17, 18. And if we don't, ideally, if we deal with it rapidly, then we can hopefully change a lifetime of misery. So as practitioners who work privately, we tend to have a lot of success due to the fact that people come to us, although I do low cost, no cost, and yet people come privately to us, and then we can get them at that first throes of an eating disorder and support them to get in and out of it really quickly. What is tragic in the UK is how long it takes for people to get support, and it becomes more and more embedded. Low self-worth, low self-esteem, shame. Shame goes alongside, hand in hand, especially with binge eating, especially with bulimia nervosa. Interestingly, anorexia nervosa is seen as a badge of honor for so many anorexics. The thinner you are, the more prestigious it is almost. And it's interesting it's extremely competitive. So if they get into hospital, they will automatically look round for the one and be envious of the one who's been tube fed. It's a real tragedy. Poor diagnosis. And this is extremely sad and has made me very angry. I've worked with people who have been given diagnoses that they never even had. I've had people given borderline personality disorders eating as a diagnosis, and they were literally malnourished. Delayed treatment. Again, if we get people in immediately, quickly, we will support them in order to get them out of this terrible illness a lot quicker. So it has to change. It really has to change within the UK. And what keeps it going is and anywhere abroad, what keeps it going is that that emotional numbness. It numbs you. It blocks out. You know, anorexia in particular, it's extremely terrifying to feel. So when I'm training, I say, don't ask an anorexic what they feel. It's terrifying, and they don't know. Equally, people who are overweight or in larger bodies, you would have the same conditions, same lack of emotions, not an access to emotions. Rapid change in the environment, you know, moving house. Lack of assertion. This is an absolute huge problem, you know, not being able to say no. So I teach people all the time how to say no to people, how to say no in order to be saying either to say no to food or no to others. And it's a need to regulate emotions. So whether we're under eating or overeating, we're doing the same. We're attempting to regulate our emotions. So if you think a thought, all eating disorders are self-traumatizing conditions. And the presentation becomes more and more and more like post-traumatic stress conditions over time, like PSTD. I've given you a list of books that may well help. So they're on 2 pages at the back. And I've given you a list of, if you'd like to train in this field, of who and where you can go to. And I will end by saying that we are absolutely desperate within the UK to have practitioners willing and able to work in this field. We have a total epidemic of eating disorders, like a huge black cloud floating over us. People think that it doesn't happen to many people, and yet it is an extremely common condition. And each and every time the National Centre of Eating Disorders trains, each time I train, the practitioners are amazed about their own relationship with food. And we have had hundreds of people over the years at the National Centre of Eating Disorders identifying their own eating issues. And every time we train, when we go back to our practice, clients will say, my goodness, thank you for asking that question. Thank you for asking what is my weight, food, shape, what is my weight relationship like with food, weight, and shape. And they will find out, undoubtedly, how many of their own clients are suffering from an eating disorder. So please think about training. The training you will do will go over every field. It will work with all addictions, substance abuse, alcoholism, gambling, any other addiction. It's cross-transferable. So thank you so much for listening, and I hope it's helped and that you will have more of an idea. And please think about getting some training. That would be amazing for all of us, especially our clients and your clients. Thank you very much.